Hello, and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, You Are the Key to HPV Cancer Prevention. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on the screen now and will appear again later in the program. Also, the handouts, the sign-in sheet, and the evaluation are all available online. You will need to register for this program in order to access those material. Please note that continuing education for today's program is being offered through the Deep South Center for Occupation, Health, and Safety and will not be provided by ADPH. Continuing education for physicians and pharmacists is only available if today's program is viewed live. To obtain a certificate online for the live program, physicians and pharmacists will follow the instructions on page 4 of the program reference document available with the handouts. Continuing education for nurses and social workers is approved for both live and on-demand viewing. For nurses and social workers viewing live or on-demand, you must watch the entire program, then complete and return the sign-in sheet and evaluation to the Deep South Center. I'm Cindy Lessinger, Director of the Immunization Division at the Alabama Department of Public Health. And joining me today, we have Natasha Horn, nurse practitioner, specialist with the Chew Clinic in Linden, Alabama. Welcome, Natasha.
Thank you, Cindy. Thank you for having me.
Sure.
And welcome everyone that's signed in now for the live webinar. We are going to be discussing the HPV Cancer Prevention Program. And as the slideshow presentation says, we are the key to HPV cancer prevention. Again, I am Natasha Horn. I'm a nurse practitioner in Linden, Alabama. I've been nurse practitioner now for about 6 years, and prior to that I was a maternal infant nurse for about 16. So HPV cancer prevention is definitely dear to my heart. If you will follow along on the slides. The presentation is also jointly provided by Postgraduate Institute of Medicine, the National AHEC Organization, Western Central Alabama AHEC, and the Northeast Mississippi AHEC. And it is also in collaboration with, as you saw there, the American Cancer Society. As Cindy went through already, the continuing education credits, you can follow through on those handouts to get registered for the CE. So we'll just kind of skip past that a little bit. Housekeeping, there's no real or apparent conflict. I have no conflict with presenting today. We'll move on to the objectives. There are quite a few objectives of today's program. One will describe the burden of the HPV disease. We'll also define the importance of HPV vaccination for cancer prevention. We'll explain the rationale for vaccinating at such a young age of 11 to 12. We'll also list recommendations for the HPV vaccine for both girls and boys now. We will provide useful and compelling information about the HPV vaccine to parents to aid in making the decision to vaccinate, locate the resources relevant to current immunization practice, provide appropriate care and counsel for the patients and for their families, as well as provide accurate and appropriate counsel as part of the treatment team. All right, we'll go ahead and get started. The first section of the presentation is going to be understanding the burden of HPV infection and disease. We'll simply break down HPV types differ in their disease associations. You have the mucosal sites of infection, which are typically your high risk or oncogenic forms, and that would be your HPV 16 and 18 are the most common. You also have the low risk or non-oncogenic forms of HPV, and those are the 6 and the 11 strands. The 16 and 18 are the ones that are linked to cervical cancer, anogenital cancers, your oropharyngeal cancers, as well as the cancer precursors that you see, where the low risk, which is the HPV 6 and 11, are your genital warts and often the laryngeal papillomas and the low-grade cervical disease. You also have your cutaneous sites of infection, which these are just your basic common hand and foot warts. Most females and males will be infected with at least one type of mucosal HPV at some point in their lives. There's an estimated 79 million Americans that are currently infected, 14 million new infections per year in the U.S. HPV infection is most common in people in their teens and early 20s. Most people will never know that they've been infected. Every year in the U.S., there are about 27,000 people diagnosed with a cancer that's caused by HPV, and when you break that down, that's one case every 20 minutes. This slide represents the types of cancers, or the cancer sites, and then the percentages and as far as the numbers that you see. So you can see there that the highest is oropharyngeal in male. The highest in female is going to be cervical cancer. Okay, and then as you go from there, males tend to have 1,400 they find roughly with anal cancer, and then 700 with penile cancer, where the females do have some of the anal cancers as well as the oropharyngeal. And now they're also finding vulval and vaginal cancers that are linked to the HPV as well. This pie chart breaks things down a little bit further, and it actually shows you the different way, data in a different way, and just kind of helps highlight the greatest burden of the disease for both women and men. So when you look at it on a pie chart, it just brings it a little bit more into perspective as far as the amount of cancers that are related to HPV. Cervical cancer is the most common HPV-associated cancer among women. There are approximately 500,000 new cases and 275,000 attributable deaths worldwide in 2008. 11,000 plus new cases and 4,000 attributable deaths in 2011. So looking at these numbers, there is a significant or a profound number of new cases and deaths related to cervical cancer. 37% of your cervical cancers occur in women who are in the age range from 20 to 40. 13%, or nearly 1 in 8, between the ages of 20 and 34, with 24% between the ages of 35 and 44. And if you look at the chart here, or the map rather, this breaks it down as far as the HPV-associated cervical cancer incidence rates by state. And if you can see there, Mississippi and Alabama are among some of the highest, which really hits home when you look at what we're dealing with as far as the cancer rates and deaths related to cervical cancer. Again, this is another chart that just kind of breaks things down as far as the cancer rates broken down by race and ethnicity. And you can see here that the black race as well as the Hispanic ethnicity group are among the highest that have the cervical cancer, and that they're the ones that would benefit even more so by following through and pushing the HPV, or encouraging the HPV vaccine. This slide just kind of shows us a little bit about the financial or the annual burden of the HPV related disease. And if you start towards the bottom there and look, there are 1.4 million new cases of the low-grade cervical dysplasia, 1 million new cases of genital warts, roughly 300,000 new cases of the high-grade dysplasia, and roughly 11,000 new cases of cervical cancer, 4,000 of those with cervical cancer deaths. Annual report to the nation on the status of cancer, HPV-associated cancers. From 2000 to 2009, oral cancer rates did increase. 4.9% for Native American men, 3.9% for white men, 1.7% for white women, and 1% for Asian men. And if you break it down and look at the anal cancer rates, you can see that doubled from 1975 to 2009. Vulvar cancer rates also rose in the white population as well as the African American population. Penile cancers increased among the Asian men. So those are just showing some of the increases that we've seen over time as far as relating to the cancers. Next portion of the slide, we're going to talk about the vaccine itself and how important cancer prevention is. We'll go through basically showing the evidence-based HPV disease prevention with the vaccine. Basically, the HPV vaccine is made from a virus-like particle that cannot cause infection of HPV, or can it cause cancer. The vaccines have been shown to prove or have been proven to show higher neutralizing antibody than just natural infection. So the vaccine does provide better coverage than actually building immunity from the infection alone. The HPV vaccines that are currently available, there are currently 3 available. First are the one we saw first was the bivalent vaccine. This one covers the HPV type 16 and 18, which are your mucosal or your oncogenic cancers. There are some contraindications there. If there's a hypersensitivity to latex, you'd want to stay away from this particular vaccine. And as far as the dosing schedule goes, all the vaccines will actually have a 3-shot or 3-dose series. The bivalent is done at once, or the initial vaccine is given, and then 1 month later, and then 6 months from the previous. The other 2 vaccines are given at time of vaccination, then followed up with 2 months, and then 6 months again from the first dose. So your quadrivalent and your nonvalent are the more recent. They actually cover against HPV type 6 and 11, as well as the 16 and 18. And the 6 and the 11 are the strands that are contributable to genital warts. So they incorporate the genital wart coverage as well. And then on the nonvalent, which is the newest, it actually brings in 5 additional strands of HPV that have been shown or linked to approximately 15% of those cervical cancers. So with the 2 Gardasil, the Gardasil and the Gardasil 9, if there's a hypersensitivity to yeast, you would want to avoid using those, or at least be aware and make the family aware, the patient aware, the parents aware, and monitor that closely. And again, that shot series is initial injection, followed by 2-month injection, followed by 6-month injection. And looking a little bit as far as comparing them, and as you can see here, it just kind of breaks it down in a little graph format. The bivalent, again, only covers 16 and 18 strand, where your quadrivalent and nonvalent cover the 6 and 11, as well as the 16, 18, and the nonvalent also covers the additional 5 strands, 31, 33, 45, 52, and 58. As far as breaking this down a little bit more, there is indication that when vaccinating the males, which is a newer trend now, they discourage using the bivalent because it only covers the 16 and 18, where with the male population you want to incorporate the genital wart coverage, which is why they recommend using the quadrivalent or the nonvalent when you're vaccinating the males. So who gets the shots, or who's recommended to get the shots? Girls and boys. The vaccine manufacturers actually say that they can start getting it as early as 9 years old. However, it is recommended by the CDC that start at age 11. That way you can go ahead and have the series complete by the time the child is 13 years old. So usually based on the recommendation, they should have everything finished up or their vaccine series by the 13th birthday. Those that have not had the vaccines, or all 3 of them, would be considered behind on the vaccine series. However, you do not have to start the series over if you were to get behind, so to speak. You just pick back up kind of where you left off, but it is very important to go ahead and to get all 3 shots in the series. Girls should be vaccinated between, again, the ages of 11 up to ages 26. So if you haven't started the series yet on your daughter, granddaughter, and they are 15, 16 years old, it's not too late. It's highly recommended and encouraged to go ahead and get that vaccine on board. And you have up until they're 26 years old to have it completed. Okay? With the males, the age is through 21. Again, you want to go ahead and encourage having your sons, grandsons vaccinated, and again, they can go up to age 21. There is an indication on males up to age 26 if they are homosexual males or they're involved in intercourse with the same sex. The vaccination routinely recommended. HPV is recommended again for ages 11 to 12 in males and females so that the series is completed by the 13th birthday. Clinicians should recommend the HPV vaccine on the same day and in the same ways that they would other vaccines. So when the child comes in for their 11-year-old Tdap and meningococcal vaccine, it's highly encouraged that we talk to the parent and say, okay, they're coming in today, they need 3 shots. They need this. And they're just very much encouraged to just present it just as you would any other vaccine. The updated ACIP, Advisory Committee Immunization Practice Recommendations, again, ages 11 to 12, recommended for females through 26, males 21, unless there is same-sex relations. Excuse me. This breaks it down and tells us again the formulation by gender, so which ones you should go with. Females, you can use all 3, or any of the 3 rather, of the immunizations, the bivalent, quadrivalent, or the non-valent. With males, again, just the quadrivalent and the non-valent are recommended. All 3 of the vaccines do protect against HPV 16 and 18. Which are the types that cause the majority of your cervical cancers. Up to about 66% of the cervical cancers are caused by 1 or 2 of these types. So the non-valent, again, targets at 5 additional cancer-causing types, and those actually are accountable for up to 15% of your cervical cancers. The 4 and 9 valent strands also protect against the HPV 6 and 11, which again is the forms that cause the genital warts. Updated ACIP recommendations, interchangeability, and this is a question that does arise. If we started an immunization series with one particular vaccine, what do we do if we don't have that particular one for follow-up? If the vaccination providers do not know what was started initially, or do not know or do not have available what was initially started, you can actually go and transition into the newer one, the 9-strand or the 9-valent vaccine. And that's the one that's being encouraged now, just because it does offer the additional 5 strands of coverage. The 9-valent is definitely the one that's encouraged to be used at this point. For protection against the HPV 16 and 18, any of the HPV products can be used and completed at any time. So if you start with the bivalent, you can continue out or finish out with either the quadrivalent or the non-valent. With the males, you should only use, again, the quadrivalent or the non-valent, just because of the coverage and the protection. The timing series, again with the bivalent, it's initial injection, repeat at 1 month, and then it's 6 months from the initial. And then with the other 2, the quadrivalent and the non-valent, you go and vaccinate the day, 2 months from the initial day, and then 6 months from the initial day. All right, is it safe, effective, and discussion about the lasting protection? As far as safety goes, the benefits of the HPV vaccination far outweigh the potential risks, and safety studies have shown that it is very similar to that as you would have the meningococcal or the Tdap. So you don't really have any other or any greater risk of issues than you would any of the required vaccines that our children get. HPV vaccine works. Population impact against early and mid outcomes have been reported in multiple countries, so it's definitely effective. The vaccine lasts actually quite some time. It's considered one of the longer-lasting or long-lasting vaccines. There's no evidence at this time of any waning protection, so it's pretty long-standing. HPV vaccine safety. This slide here breaks it down. Vaccine efficacy, ability for the vaccine to work. I'm blind and can't read that little writing. As intended, protect from illness. Yes. Vaccine-associated risk, probability increased adverse event that harmed the individual or population. So again, this is us weighing. Thank you, Cindy.
That's what I'm here for.
All right. Taking it down further to the journey of your child's vaccine. And this is how a vaccine safety continues to be monitored. And that's a very important thing to be aware of, and something that all healthcare providers, nurses, those that are administering the vaccine really need to be aware of and can present to the parent or to the grandparent, because their child or grandchild's safety is of utmost importance to them, of course, but also to us, the ones that are actually given the vaccines. So you do have safety constantly being monitored here. The FDA as well as the CDC are constantly monitoring or closely monitoring any new potential adverse reactions that might occur, so that they have those available to present. Let's see, a couple of the processes that they use are the VAERS, which is the Vaccine Adverse Event Reporting System, and this actually collects and analyzes reports of adverse events that happen after a vaccination, any vaccination, which would include the HPV. The VSD is the Vaccine Safety Data Link, and it's actually a network of healthcare organizations across the U.S. that scientists use to conduct studies evaluating the safety of the vaccines. And again, this includes HPV. These studies determine if possible side effects are actually associated with the vaccine itself. These systems can actually detect rare adverse events that were not identified during pre-licensing clinical trials. So continuous monitoring is very important, both to of course, the population, but it's also important to the manufacturers of that particular vaccine. So that's definitely something that the FDA and the CDC work closely in monitoring. The VAERS safety monitoring is an ongoing safety monitoring process, and it reports most of the reports are non-serious that they've shown so far. Among the 7.6% of reports coded as serious, most frequently cited possible side effects of headache, nausea, vomiting, and fever. And again, that falls into what they would classify as what they've seen as the most serious. Brief fainting spells and related symptoms, as far as jerking movements and that sort of thing, can happen with any medical procedure, including vaccines. And in a lot of cases, this is more of a vagal response that we see. That doesn't necessarily mean that it is a adverse quote-unquote effect. It's a typical response that some children have, or adults for that matter have, when they receive injections. So that is something that should be explained prior to, and let the parents know and grandparents know that this is a normal response. In an event like that, we encourage that you keep the patient or the child there for about 15 or 20 minutes, sitting or lying, just to monitor them, and normally within that time frame, they don't even realize that there was ever even an issue. Again, this slide talks a little bit more about the syncope or the fainting that can occur with that. The VSD rapid cycle analysis, the RCA, which is short for rapid cycle analysis, allows the VSD to detect any adverse events following a vaccination in near real time. So after approximately 600,000 HPV-4 doses among females, no significant risk for any of the nonspecific adverse events after vaccination were seen. And this breaks it down to include seizures, appendicitis, stroke, venous thrombosis or thromboembolus, or allergic reactions. And these studies were actually done not only with the HPV, but with all of your immunizations that are required. Ongoing HPV safety activities at the CDC. They review the reports to VAERS to search for any unusual adverse events or changing patterns in those events. The VSD also addresses HPV vaccine safety in special populations. So they focus also on your safety among the males, since this is fairly new regarding the male vaccinations, and as well as any inadvertent 4-valent HPV vaccinations during pregnancy. There aren't very many studies done. Of course, when you're pregnant, it's discouraged to get any vaccinations at all during pregnancy. However, at this time, they've not shown any, they're monitoring that and haven't shown anything highlighted at this point. Ongoing HPV safety activities at the CDC. The VSD addresses HPV vaccine safety that may arise from case reports and or the media, which we all know that there's plenty of that going on right now. So they are aware of what's going on or what's being said in the media as far as potential side effects or adverse effects coming from the vaccines, and they're on top of that and constantly doing studies and addressing these situations or these concerns. There has not been, a large population-based safety study conducted among the males who have received the HPV. So the VSD will actually be evaluating this population a lot more closely, as well as that with the pregnant population, and looking at any potential adverse events once the delivery and child have been born. Non-CDC HPV vaccine safety activities. There are, sorry about that, bring it back a little bit. Post-licensure commitments from the manufacturers. I just briefly touched on that. And again, they are doing their own studies and monitoring their own adverse effects, and they're looking at the vaccine and pregnancy registries as well as the long-term follow-up in some of the Nordic countries. Official reviews, other organizations that are monitoring and safety activities with regards to any vaccines. Your WHO's Global Advisory Committee on Vaccine Safety 1. This is an organization that is also monitoring vaccine safety, as well as your Institute of Medicine's report, and they issue a report as far as adverse effects in vaccines. Key findings, CDC and non-CDC. And some of the reports or studies that they're looking into, again, they're looking into possible adverse effects that are the most detrimental, one being venous thromboembolus, or DVT, among the females 9 through 17, or 9 through 26 rather. And preliminary studies have shown that there is no increased risk of venous vein thrombosis with using the HPV vaccine. Also, another non-CDC study concluded as well that, again, there's no risk or no increased risk. They've not confirmed any risk of DVT or venous thrombosis embolus in using the 4-strand HPV vaccine. Autoimmune and neurological conditions, again, there's no association between giving the quadrivalent vaccine and 16 autoimmune conditions. The adverse effect or side effect of injection site reactions and syncope, no major safety concerns there. Of course, the most common thing you see with injection site would be some redness, maybe some swelling at the injection site. And again, with the syncope or the fainting episodes, that's more or less a vagal response, and that can be seen with any injection. Doesn't even have to be vaccine. It can be any injection at all. The Institute of Medicine review, as far as syncope and anaphylaxis, Possible associations between 8 vaccines and adverse events. Evidence favors acceptance of a causal relationship between HPV vaccine and anaphylaxis. However, that is rare. And evidence convincingly supports a causal relationship between injection of a vaccine and syncope. Again, those are just casual and not life-threatening. Inadequate evidence was found for causal relationship between HPV vaccine and 12 other specific health events that were studied. The non-valent HPV vaccine safety, 7 pre-licensure studies including 15,000 males and females were participated in this study. It was generally well tolerated. Adverse event profile was similar to that of the 4 or the quadrivalent HPV vaccine across age, gender, race, and ethnicity. There are more injection site reactions that were expected with the non-valent, and that's because the number of additional strands that are in with it. The vaccine impact, early outcomes, HPV prevalence, genital warts, mid-outcomes, years, which would be years to decades. That would be your precancerous cells as well as your CIN or your low-grade dysplasias, and your late outcomes, which could be decades. That would be your HPV-associated cancers. Monitoring impact in this slide just indicates the monitoring impact of the HPV vaccine with those outcomes. Vaccine impact monitoring. Post-licensure evaluations are important to evaluate real-world effectiveness of the vaccines. Population impact against early and mid outcomes have been reported. With genital warts, areas that have shown impact are in Australia, New Zealand, Denmark, Sweden, Germany, Quebec, and the U.S. So those would be more of your European and Nordic areas, and then of course the U.S. HPV prevalence was seen in Australia, Norway, Denmark, Sweden, the UK, and the U.S. Cervical lesions were seen more in Australia, British Columbia, Denmark, Sweden, and U.S. And so as you can follow that there, U.S. pops up in every one of them. So it's very, very important that we really focus in and that we really push the vaccine and get that out there to our young females. National Health and Nutrition Examination Survey data was used to compare the HPV prevalence before the start of the HPV vaccine program, which would have been between 2003 and 2006, from the first 4 years after the vaccine was introduced. The results showed 14 to 19-year-olds vaccine type HPV prevalence decreased by 56%. Other age groups did not show a statistically significant difference over time, but looking back at that 14 to 19-year-old group, 56% reduction after the program started or the initiative started. That's amazing. Vaccine effectiveness for prevention of infection was estimated at 82%. So we're still not quite there, but we're getting there. The next few slides just kind of show a little bit about over time and the prevalence and the age groups of where the prevalence there as far as the anogenital wart prevalence with the females. And again, the impact of the HPV vaccine in Australia, as you can see here, there was a drastic drop after the initiative started from 2007 to 2011. The age group less than 21, which is in the blue solid line, there was a significant decrease. And again, this breaks it down as far as vaccine in Australia. Systematic review and meta-analysis of the population-level impact of HPV vaccine. A review of 20 studies in 9 high-income countries. In countries with greater than 50% coverage of the vaccine among 13 to 19 years old, HPV 16-18 decreased at least 68%. Anogenital warts decreased by approximately 61%. Evidence of herd effects. So, I mean, you can see there, you can see the benefit of the vaccine itself when you compare it back to the lack of, I guess you'd say, data to show the dangers, okay? Some evidence of cross-protection against other types were shown as well in these studies. Challenges in monitoring the HPV vaccine impact on cervical lesions. This is detected through cervical cancer screening, which would be your pap smears. Changing screening recommendations. This is a challenge because those screening ages are becoming later and later. Lack of cervical cancer screening registries in some countries. Incomplete linkages with vaccine registrations or registries. HPV vaccine duration of immunity. Studies suggest that the vaccine protection is long-lasting. There's no evidence of waning immunity. Available evidence indicates protection for at least 8 to 10 years. So we know if we can get this on board, we know that they have at least 10 years of coverage. Multiple cohort studies are in progress to monitor the actual duration of the immunity. So there are studies in place to see just how long the immunity is there. All right, this breaks it down as far as the 3-dose coverage. And you'll see there that Australia did an excellent job of getting all 3 vaccines or immunizations on board. The UK, 60%. Then we get down to the US, which only shows 33%. Only 33% of our girls in the United States actually went through or got the entire series. That's sad. I mean, it's sad. That's sad. That's right. That's right. Adolescent vaccine coverage in the U.S., again, this just shows, breaks it down between the years of 2006 and 2014 as far as how many got the first shot as opposed to the second and third shots. This slide is very hard to see, but if you look, I think I might actually have it here. It breaks it down by state, and the girls aged between 13 and 17. If I remember correctly, Alabama and Mississippi are way, I don't know that lights, but way down here, way down here. We do. We do. We have a long way to go. Again, which is why we're here. Yep. The impact of eliminating missed opportunities by age 13 in girls born in 2000, we went from 47 that actually did receive the vaccine to 47% to 91 that were achievable. I mean, we missed half of these girls. Half of these girls got missed as far as even having the series initiated to them. So, talking about the HPV vaccine, how are we going to frame this conversation? And that's, that is an issue. That's when coming from a rural clinic, you come in and it's time to give those immunizations. And if you don't really know the approach to take with some of the parents, you go across as well. We need to get this vaccine, this vaccine, this vaccine. Well, what is that for? Well, HPV, protects you against cancer, cervical cancer, or genital warts. And automatically that sends up, whoa, my child's not sexually active, my daughter, my granddaughter's not sexually active, we don't need that. And that's where a lot of the miscommunication comes in, and I think that's where a lot of the girls are getting missed, and even the boys are getting missed, because it's not being presented in a way that is actually the correct way, really, that is actually telling them, look, this isn't about being sexually active or not sexually active. This is about protecting your daughter or your son or granddaughter or grandson against cancer, okay? And if it's presented in that way, a lot of times the parent or the grandparent is like, oh, that puts it into a whole nother perspective. If someone were to have told me, many, many years ago when I had my first daughter, well, hey, this isn't about consenting when the vaccine first came out, giving her consent to have sex, at a young age, but said this is protecting her against cervical cancer. I think that my initial outlook would have been a lot different. Now I look at it completely differently because I have done research on it, and I do, I do support it, and I do present on it, and I think that it is a very, very good thing. very good thing, especially when you look back at the numbers of cervical cancers that are out there that could have potentially been prevented had we protected our children. And, same with genital warts. That's something that doesn't go away. That's something that they deal with long term, and that's something that we could have prevented, if we'd have known or been encouraged or just given the information that we needed. Clinicians underestimate the value that parents place on the HPV vaccine. And this was surprising to me when I was reviewing the data. We estimate when you're dealing with meningitis, hepatitis, pertussis, influenza, the adolescent, the primary adolescent vaccines, the parent actually is like, yeah, they're on board, with it. But it's the provider as far as encouraging the vaccine is on board with all of those major ones because they're quote unquote required, I think, by the state, and I think that's why we push it. Yeah, why we push it so much. But again, it's HPV just wasn't pushed by the provider. And that's something that we, myself as a provider, needs to keep in mind, needs to focus on. Give strong recommendations to receive the vaccine between the ages of 11 and 12. Again, it's not about the reasons that they weren't done was lack of knowledge, not needed, or the parent felt it was not needed. There were safety concerns. But again, there's a big portion there that simply they weren't given simply because they weren't recommended by the healthcare provider, which is an area that we do need to work at. Why do we give it at such an early age? Again, this strong recommendation from you is the main reason that parents decide to vaccine. Some of the questions have come up. Why are we going to do it so early? Why would you vaccinate against something that would relate to cervical cancer and genital warts at such an early age? And the reason for that is you want to make sure that these kids get the best coverage out there. We want to get them protected before they're introduced to a situation where they could be exposed to the virus. So, a couple of techniques or things that's recommended that we do as far as approaching our parents is to make it a bundle recommendation. And basically that's when you go in and you say, hey, good morning, so-and-so needs 3 shots today or 3 immunizations today. One of them is to protect against pertussis, one of them is to protect against meningitis, and the other one is to protect against cancer. Again, with talking with the parents, you need to address the parents' questions. And again, this just touches back to what I said, help them understand why it's needed to, at such an early age. Because again, a lot of parents are like, I don't know if we really need that or not. So you need to stress to them, the reason we do this at such an early age is because we want to make sure that there is enough immunity on board before our children are exposed or potentially exposed. Again, you're encouraged to emphasize your personal belief in the importance of the HPV vaccine. And as I indicated earlier, I wish that had been done with me many, many moons ago with my older child. And again, that's something that now, I do in talking with my moms and grandparents about vaccinations. Make effective recommendations, and this is very important. Be familiar with the side effects. Be familiar with the various recommendations. So that way when you're questioned by the parent or the grandparent, you can give them effective, and accurate information. So recommend the HPV vaccine the same way you would the Tdap or the meningitis vaccine at this point. Again, make sure that you recommend it on the same day that they're getting the other vaccines. If a parent were hesitant, this is a little program, or not program rather, but a little analogy you can use. Ask, acknowledge, advise, and remember. Again, ask the parent, what are your concerns? Maybe there may be a misunderstanding, so clarify that. Ask the parent, what is your concern? And have them restate that to you. Acknowledge. Let the parent know that you understand, or you emphasize with them, or empathize with them rather, that yeah, you understand that there are concerns, and you appreciate or respect their concern for the well-being of their child, and also let them know, so do I. You know, that's what we're here for. We're here to take care of your children. We're not here to do anything to harm your child. But acknowledge, though, that you do understand their concerns and that those are valid concerns for them to have. Advise them. Clarify with them what their misunderstanding is, and allow them to break down the pros and cons. You know, this might be a time where you might need to pull in, say, your nurse, if you're the nurse practitioner or the physician or healthcare provider. This might be the time to pull in the nurse to say, hey, you know, go over this with them, you know, if you don't particularly have the time at that point. But it's very important to advise and to allow them to discuss the pros and cons with the vaccine. And remember that if they decline on that particular day, that's not a final, okay? We still have time. Just because they come in and they get their Tdap and meningococcal vaccine and they're 11 years old and we think, oh, well, they're done, you know, for 10 years, we don't need to worry about anything. That's not the last time you have or the last opportunity you have to see this child and to encourage this vaccine. So make sure that you remember that if they refuse or decline, you know, there are other opportunities. Don't forget or don't, you know, put it aside and say this is the end of the conversation. Okay? Make sure that the next time you see the child, whether it's for a well-child visit or, you know, whatever, say, hey, you know, have you thought any more about the HPV vaccine, you know, and just encourage them and reintroduce that conversation, okay? Because the more you introduce it and the more of an opportunity the parent or the grandparent has to actually sit down and talk more about it with you, they'll come to realize, you know, those concerns that they have maybe are a little bit, they're not as warranted, you know, and that would be the perfect opportunity to get the vaccine on board. So don't forget, you know, always remember, if they decline on that initial visit, it's okay, you know, give them information, send home literature, something for them to review, something for them to look up, give them a website they can go to, something just to let them know, you know, hey, there's this information out there, you know, this is important. So make sure that you understand that just because they decline it does not mean that that's your last opportunity. Some parents need reassurance. So again, that some parents may accept the bundle approach. You know, they've got to get blah, blah, blah today. And they go with it, you know, and that's great. Those are the easiest ones to do coming from that, you know, that end of it. But then you are going to have parents that are going to say, wait a minute, what do you mean protect against cancer? So make sure that you are familiar enough with the vaccine to be able to give them the information. And if you don't know it, have those resources available, and that something you can present them with. Clinicians can give a strong and effective HPV vaccine recommendation by announcing, simply go in the room, Sophia's due 3 vaccines today. We're going to vaccinate against meningitis, HPV cancers, and pertussis. And we'll have all those shots done at the end of the visit. And just take it just like that. And again, a lot of the parents will go with it. They're like, okay, this is what we're doing today, and we're going to do it. You can also take the approach of, if there's a question, you know, why does my child need this vaccine? We'll simply say that it's important protecting against cancer, and that I know we'd like to protect Maureen from cancer, and I'd feel better if she got her first dose of the HPV vaccine today. And if you go that route of being encouraging, and you know, normally the patients or the mother or the father or the parent, grandparent, they're going to follow suit. If the main concern is my daughter will wait for marriage and won't be exposed, make them aware that they may not be exposed until marriage, but that doesn't necessarily mean that their husband or their partner won't be. Okay, so that's very important to keep in mind, because that is actually something that I've encountered, a statement that I've encountered during my practice of, well, you know, my child's not sexually active. She doesn't need this vaccine. And it's not that we're implying that she is. It's that we want her protected in the event that her partner, you know, was not, and her partner actually has HPV. So, I mean, that's something definitely to keep in mind. If the main concern is why now, let's wait until my child is older. Again, stress to them. We want to make sure that your child has the immunity that they need before they're exposed or potentially exposed to the virus. HPV vaccine will be a green light for sex. Studies have shown that getting the HPV vaccine doesn't make kids any more likely to have sex than not have sex. I don't think giving the vaccine is saying, woohoo, go have sex. So don't, that's definitely not something that really needs to be a concern. It's not. It's not a green light for sex. And in a lot of cases, you tell the child, this is an immunization you have to have. Who says you have to tell the child, well, this is the immunization that you have to have for blah, 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 Let them know this is a required vaccination to protect you, okay? And very rarely do kids even ask. I know in my clinic, even with 11 and 12-year-old kids, we're having a hard enough time just getting them still to get the immunizations, much less them being concerned about what they're getting immunized for, So it's you just don't even think of that as a concern. Would you give it to your child? And this is a very loaded question because, as I said initially with my oldest daughter, it was so new that there wasn't someone to just really tell me. And just because at the time I was an RN, I wasn't, I worked in maternal infant care, but again, that was not something we dealt with on a regular basis, so that's not something I knew a lot about, so I think being encouraged or just having the information more readily available, I think that my initial approach would have been a little bit differently. Now that she's older, I'm older, I have another daughter, they're both getting it. So, it's one of those things that, yes, if you're asked that question, be familiar enough and know, but realize the importance of it, and especially not taking away from sons, but having a daughter and having that potential for cervical cancer. If there was a way to protect against that, why not? Why not protect against it? If main concern is side effects, try saying vaccines, like any other medications, can come with side effects. Go through with them, that normally they're very mild. You might have some redness or some soreness or a little bit of swelling at the injection site, but beyond that, those things should go away quickly, and there are no more, there haven't been any more or been linked to any more serious adverse effects or long-term effects than any other injection or medication. Possible effects on fertility. There are no detrimental effects of getting the vaccine on a female and fertility. However, repetitive exposure to the HPV virus, there is, okay? And that's something that needs to be stressed, all right? HPV can cause cervical cancer. It can also cause multiple other cervical issues that can potentially leave a woman infertile. So you need to make sure that, if that comes up, no, the vaccine does not affect that anyway, but understand that the HPV virus will. And before leaving the exam room, again, reiterate. All right, Robert needs ABC today. We're going to give him the vaccine against, pertussis, meningitis, and HPV cancers. All right. Some of these I'm going to flip through just for time purposes. Increase the number of target patients, some of the things that we can do. One is standing orders is probably the biggest thing. As far as having standing orders available to you in the clinic. Make sure that the whole clinic is on board, and that's important, and that's from physician to nurse practitioner or PA, whatever your mid-level provider is there, to the nurses, to the front staff. Make sure that everybody is on board and is aware of your mission, okay? Because it starts with the front. The child comes in, we're here for immunizations. The front staff can be like, okay, we'll get you registered. And if they were to ask, yes, you're going to get 3 shots today, ABC. Then again with your triage, and again with your nurses. So you've got to be on board. Everybody's got to be on the same page. Because the more a patient or the more practitioners or healthcare providers or nurses or staff that go in and say, okay, today you're going to get vaccinated against ABC, and then the next one, today you're going to get, vaccines against ABC, then it just stresses to the parent the importance, okay, of why we need to do this. So make sure everybody's on board. Standing orders is a good thing because that's something that your nurses can do for you before you ever even get in the room. So-and-so's here strictly for immunizations today. They're afebrile. There are no complications. This is what we're going to get today. They're out, they're there, they're ready. All you have to do is go in and see the patient, talk with the mother, talk with the grandparent, whatever, and they're done, And so that's very, very important. Some of your electronic medical records, too, can have alerts set, which is also a very good process, that when the patient comes in and you open them up on the EHR and it's time for the immunizations, the alert pops up that says, oh, they're due for their immunizations today. They might not have come in for immunizations. They might have come in for a sprained ankle or, something along those lines. And that's our reminder that, hey, they're doing immunization today. So let's go ahead while we're here. Let's go ahead and get those on board. So everyone should be on board or in the office as far as understanding the mission. Standing orders we talked about, and there's actually, if you want to review the slides at a later time, www.immunize.org/standing orders actually has templates that you can print off in your practice for that. Again, standing orders saves the physician's time. Oh, and that's the end of our presentation. We do have some review questions here, but if anybody has any questions they want to call in or email, okay, or email, then we'll address those as well. But I'm just going to hit these few really quick. HPV vaccine is recommended for the following persons: all adolescents at 11 to 12 years old, females only at 13, males only at 11 to 12, females only at 11 to 12. And that's going to be, of course, all adolescents. Why should males receive the HPV vaccine? Prevention of infection with HPV types 6, 11, 16, and 18. Prevention of genital warts. Prevention of anal cancer caused by HPV. Or all of the above. That's all of the above. And my last little review question. Which of the following HPV vaccine recommendations for a child aged 11 through 12 is most likely to be successful? Ask parent if child is sexually active and then discuss importance of HPV vaccine. Tell parent that their child needs 3 vaccines to prevent meningitis, HPV cancers, or pertussis. Tell patient about the vaccines that are mandatory for school entry and ask if they also want the HPV, or ask the parent if they want to get HPV vaccine for their child or want to wait until the child is older. We're going to tell, we're going to tell that parent that their child needs 3 vaccines to prevent meningitis, HPV cancers, and pertussis. The next few slides, which you'll have as well, those actually are reference materials, links that you can go back for continuing ed pertaining to HPV. And again, the fact sheets for the parents in both English and Spanish. And all of these are available at the CDC website. So you can get all of this information printed off free of charge. The Merck rep, I know he comes through and sees us in our clinic fairly regularly, and he's constantly bringing us literature. So, utilize your drug reps. They have this information typically with them. Put these charts up. Put them up in your rooms. Put them up in your waiting rooms, in your hallways, in your triage areas, just so that the patients or the parents of the children of the patients are familiar and aware and know that that's there for them to protect them, and in some cases may prompt a conversation. Even in a younger age child, it might say, oh, okay, well, we're looking at this. Tell me a little bit about this, so I know when we're 11, what we need to look forward to. So any opportunity you have to present the information to the parent or grandparent is just valuable. So I highly recommend and encourage all level healthcare, whether it's the physician, any mid-level, the nursing staff, all of them, be familiar and encourage, because we are the key to cervical cancer, HPV cancer prevention. Okay?
Thank you so much.
Thank you for having me.
That was a lot of really good information.
Thank you.
Even in my position, I don't think I've thought about all of those different angles. One thing I wanted to ask you about was, would you ever mention anything about hepatitis B being a cancer prevention vaccine that we give now at birth? You don't want to wait until you're exposed. We give it to you way before there's even a possibility. So I mean, that's another example of a cancer prevention vaccine.
It is.
And then to wait for a parent to want to wait until they're exposed, that means we want to wait until you're exposed to measles, and then you want to get measles vaccine.
Right.
So yeah, those were a couple things I hadn't really even thought about until today.
Right. And it's very important, and a lot of that is, and especially where you are where I practice is a more rural area, and there is, there's a lot of information that moms, dads, grandparents, they don't know, and so they look to us, or they count on us to be the ones to help them or to make them aware. And in a lot of cases we're the primary health care for these kids. They don't go to the pediatrician. They don't go, they see us. They see us for everything. So, in the rural setting especially, you need to make sure that you are familiar and that you are encouraging, and that, you have this available to them.
Yeah, here in Alabama, I'm not sure about Mississippi, but I know in Alabama we have almost 30 counties without a pediatrician. So we know how important your practice is to the children of Alabama, and that you are their primary educator for vaccines. So we really appreciate that.
Thank you.
All right, so I'm going to move on, if you'll hand me the clicker. I'm going to talk to you a little bit about the Alabama Register, and then we will have Valerie Woods from Mississippi talking about the Division of Immunization, the Director of Immunization, about their registry. We have Imprint is what we call our Immunization Information System, IIS. So most states have been granted money from CDC to create these registries. Ours has been in place since about 1996, and it has grown tremendously. Ours is a birth to grave registry. We want to accept all people, all ages, and their vaccine history to make life easier for them. And as we have more and more adult vaccines, it's really important to keep up with your immunization history and what you need in the future. So with our registry, we call it Immunization Patient Resources with Integrated Technology, or Imprint, and that has changed over the years. The acronym has always stayed the same, but we've changed what it stood for several times. But we have several benefits that we want to make sure the providers in Alabama who are not participating with Imprint understand why they should be participating in the registry. The first one is we have now mandated that the only certificates of immunization for Alabama schools, public, private, and daycares, have to come out of Imprint. So there's a couple of ways that can occur. If you are onboarded with us, and this is getting a little more technical than I wanted to get here, but if you're onboarded directly and interface with Imprint, then you would consume this one web page, and then you will be printing directly out of Imprint. Or you can go to Imprint directly and type in the patient's information and print it out of the registry. And then down the road, you're going to be able to do bidirectional, which means instead of just pushing information to the registry, you'll push and pull it back. So we have several different ways. We're capable of doing all of those, so we encourage providers to start looking at bidirectional if they haven't yet. The other thing that we have for providers specifically is the Vaccine Forecaster tool. It is not to take the place of your medical decision, but to make sure that you are looking at the history of the patient. It tells you all the vaccines they've been given and all the vaccines they need in the future, but it also calculates what vaccines are invalid. If somebody gave it to them too early, it will show up as a red invalid, and that dose would need to be repeated. So it gives you a way of correcting any inadvertent mistakes. It could be also data entry, so that has to be taken into account, but it's important for them to see the whole picture of the patient. And we are going to move some of that information into the immunization card so that the patient or parent will also have that, so that they understand that the child needs 3 vaccines today at 11 or 12, and then they need another one at 16 to 18, and then they need going all the way out with all the current ACIP recommended vaccines. The other one is, of course, it's available in print. The registry is available with or without HL7. And the MU stands for meaningful use, and so the Center for Medicaid Services is providing money to providers to create that interface with us, but you don't have to have that to use Imprint. You can just log into it and you'll have the same access as everybody else. And then if you are an HL7 provider, we have reports that we want to make sure that you are looking at so that you know that your shots are going into the system. We have had some providers complain, well, I put it in, but I don't ever see it in the registry. Well, there are some reports that tells you which ones are not and why and how to fix them. So we want to make sure the providers know that. And I wasn't going to go into much more than that. We just want to make sure that people go and enroll in Imprint. It could be any type of provider. If you are trying to assess, we do have one clinic that will never give a vaccine, but they want to assess the vaccine history for the patient and just say you need more vaccines. And so that's fine with us as well. They don't actually have to be putting in vaccines. If they're going to utilize it for patient education, that's fine with us. You need to register each and every site individually and then each user at that site. And then if you want to do the meaningful use route, then we have a separate security portal. So the provider and or vendor needs to go to that security portal. And then you can call us here in Alabama at 1-800-469-4599, or you could email us at immunization@adph.state.al.us. I did not put that on the slide, and I apologize. So this is an example of the vaccine forecaster. We have pulled up a test patient, and if you see the shots in red, it shows that there was a problem with that shot. But if you go down a little bit further where it says recommended vaccines, so there's what was given and which ones were valid, what are the recommended vaccines going forward, and what are not recommended, so that it's taking into account all ACIP recommended vaccines. So they will know what needs to be given now. So on this particular test patient, only the MMR is due now, and it's due now because they gave it below the minimum age up above. So, and then it will give you the date everything else is due. So if you are a meaningful use, MU, HL7, and HL7 stands for Health Level 7 Interface Report, we have 5 reports for you so that you know that you're connected, that your electronic health record is connected to the registry. We also have a report on vaccine that has actually gone over into the registry, and then we have an error report, and that's what most of them need to be looking at. They need to see what the errors are and to see how to fix them so that it will show up in their vaccine report. And then we also have 2 reports, ongoing submission by site and then ongoing submission by NPI, or National Provider Identifier. So each nurse practitioner, PA, MD, or pharmacist. Alrighty, so let me skip over now to Valerie Woods. She's the Director of Immunization for the Mississippi State Department of Health, and she is on the phone with us today, and she's going to talk a little bit about her registry. Valerie, are you there?
I'm here. Thank you.
Wonderful. Thank you, Valerie.
Okay, well, good afternoon, everyone. I'm just going to give you a brief overview of the Mississippi Registry. The Immunization Registry in Mississippi is referred to as MIX, and that stands for the Mississippi Immunization Information Exchange. Now, MIX came about as a result of the Mississippi Child Immunization Act of 1994. The Mississippi Child Immunization Act of 1994 established a centralized registry to be operated by the Mississippi State Department of Health for healthcare providers to report all childhood immunizations given in the state. So every health-related facility in the state of Mississippi is required by law to report all immunizations given to anyone under the age of 19 years of age. Data is captured through the electronic HL7 exchange from provider EMRs and through direct data entry. And providers are also encouraged to enter adult vaccinations. The goal of the Mississippi State Department of Health immunization program is to ensure that accurate and valid immunization data is available to healthcare providers, parents, and others who have legitimate and tangible interest in immunization information. So information in the registry is currently used by public health care providers in Mississippi and approved participating private providers. Other private providers, parents, legal guardians, daycare operators, school nurses can call us at the State Department of Health and obtain immunization histories on children. Healthcare providers may request access to MICs and input data as well as review immunization histories by contacting us, but to be entered into the program as far as entering vaccinations, they complete and submit a mixed user agreement. And like Cindy was saying, for Alabama, each clinic is enrolled and then each user is signed on. And the mixed user agreement can be printed from our website. And for more information, you could contact the Mississippi State Department of Health Immunization Program at 601-576-7751 or 1-800-634-9251.
Thank you, Valerie.
Thank you.
The reason we wanted to include registry information with the You Are the Key is we think that would be very important. You know, the main purpose of the registry is to make sure that we're not over-immunizing children or patients and not under-immunizing. So we want to make sure that we know what their history is so that we give them the proper dose at the proper time. You know, we have seen in the past where kids have had like a DTaP have had lots because they didn't have the history. If they move around, then this is one way to collect the information and make it as usable as possible so that we know they went to see Natasha and they got 2 shots of HPV and they're now here in Montgomery County Health Department. If we look in the registry, we'll see what she's put in and then we'll know exactly what to give. Is it on time? Is it, are they ready to receive that 3rd dose? So there's a lot of benefits to the registry. Registries are the future for all immunizations, and we encourage all providers. And here in Alabama, we also register pharmacists. We have also enrolled our public schools this past year. We've given our school nurses the ability to print out an up-to-date certificate of immunization, and they can enter in history, and we're about to start enrolling private schools and daycares, not for the history part, but for the certificate of immunization. So it continues to grow, and we want to make sure everybody understands how that fits in the immunization picture. All righty. So next we have Christina Bays. She's from the Yellow Umbrella Organization. She is a cervical cancer survivor story. Welcome, Christine. Are you on the line?
Thank you so much.
Thank you so much. Tell us about your...
It's so wonderful to hear so many people getting the accurate information about the importance of the HPV vaccine and what it can do to help save fertility and lives. And for me, as a cervical cancer survivor, I advocate for it and the appropriate screening, and I've been doing it for 16 years. I was 31 years old when I was diagnosed after 13 normal pap smears. So I'm the girl that I went in every year. I did everything right. I was a non-smoker. I was with my husband for 10 years. Never had an STD. I was like total yoga, vegetarian, healthy, happy. I was happy. I had my whole life in front of me. And then I went in for my routine pap, and it came back abnormal for the first time ever. And when I went back in to get the biopsy, a colposcopy, and my doctor explained to me that he saw these cells changing on my cervix. He thought it could be moderate or high-grade dysplasia, and he was going to take, these pieces of my cervix and send it off to, get looked at and then let me know what was up. And I was like, oh, wait a second, what do you mean? What could be up? And he explained that if I walked out of his office and I didn't return for 5 to 10 years, that this could potentially become cervical cancer. And I was just blown away because you're not expecting to hear that at 31 years old when you are seemingly super healthy. And yet he really, at that time, believed that I was not going to be one with cervical cancer because of my history of normal pap smears. Therefore, it was a big surprise to him as well as to myself when the report came back that I indeed had invasive cervical cancer with a potential for lymphatic invasion, and that I had to have a hysterectomy immediately. And as a 31-year-old woman, I had been with my husband for 10 years, and we did not have children at that point, but we did want to have children. And to be told that I was never going to be able to have a little Christy with curly hair that wants to play the piano, was a devastating blow to me. And yet, there I was on April 18th, realizing of 2000 that was never going to be an option for me. 10 days later, on April 28th, I had a radical hysterectomy, and they removed the top third of my vagina, my cervix, my uterus, my fallopian tubes, all of the pelvic lymph nodes and connective tissue. From that, they determined that I did have extensive lymphatic invasion on my cervix itself. In fact, it was the pathologist at Mass General Hospital where I received my treatment, who'd been seeing slides from all around the world for 20 years, said this was the most lymphatic invasion he had seen on a cervix ever. And so I was not done with my battle. After that, I did have a laparoscopic surgery to try to get my ovaries out of what was going to be the frying zone because, like I said, I did want to have babies, and my sister-in-law said that, hey, maybe you can take, something from your ovary and put it in the petri dish with Roberts, and, I can carry it for you. So they went in to try to move my ovaries, and the left one had already been too destroyed from the original surgery, so they left it there. They carved my right one out of my colon because it attached itself there, and they tacked it up under my right rib cage. And then they started the light show, and this light show was in the basement of Mass General, and it consisted of 5 weeks of daily pelvic radiation. Concurrent with that, on Tuesdays I would go in 5 hours early, and I would get chemotherapy. I would have cisplatin pumped into my PICC line that was to enhance the effects of the radiation that I was getting. Following that, I then had 3 rounds of internal radiation, and that's where they insert something into my already scarred, fried, hurting vagina, and they blast you with high-voltage radioactive rays for 10 minutes at a time. It's called brachytherapy. And that was it. That was July 27th was my last treatment. So if you think about that, from April 28th, my hysterectomy, to July 27th, my last treatment, it was like my world turned upside down that summer. And everybody knows and can see physically the effects of cancer and cancer treatments. You see the loss of weight, the loss of hair, the yellowing of skin, no sparkle in the eye. The thing that you can't see is what happens on the inside emotionally, the psychosocial impact of cancer, and on anybody who loves that person that had cancer. It is quite devastating. And my day gig is a marriage and family therapist. I do outpatient mental health work. And so I know a lot about depression and anxiety and PTSD and all that stuff from one angle. But during this cancer experience and what followed for me was an incredibly dark depression. I became helpless and hopeless. I really didn't know what I was going to do with my life anymore. I was a musician as well, touring around up and down the East Coast, and my band had gone on to play with other people. I didn't even feel like playing the piano or singing anymore. I didn't enjoy the things that I used to, and I pushed friends away because I just didn't feel like myself. And I sat in that depression for quite a while before I said, whoa, I just kicked cancer's butt, and now I'm sitting here depressed. I'm not going to let depression keep me down. No way. I just worked too hard to be alive. So I did everything I could. I got a therapist. I got on an antidepressant. I joined a cancer group. I joined a young adult cancer group so that I could connect and identify with other young adult cancer patients that are being affected with fertility issues and lifelong side effects from treatment. I did acupuncture and Reiki. I got back into my yoga routine. And eventually, I started to feel like myself again. And it took a long time for the music to come back, but I did get inspired by watching a movie called Harold and Maude. And Maude is this 79-year-old woman who just loves life. And I saw her spirit and her energy, and I saw her carrying a yellow umbrella from a funeral. And that image and her just love of life really impacted me, and I felt alive again. And I went to my piano and I started playing and singing, and that's when I knew that cancer did take a lot of my bits and pieces, but it did not take my voice. It did not take my soul. And that's when I decided to return to life and to do something about this issue, because I was a very proactive, educated young woman, and yet I had never heard of HPV. I didn't even know what the Pap test was for. I just know that I had to go every year. So when my doctor did explain to me that it was caused by HPV, that this was a virtually ubiquitous virus that everybody can be exposed to, and it's just a matter of your immune response, and that the Pap test, I said, well, so the Pap was supposed to catch these cell changes, right? And she's like, yeah, and unfortunately, the old school Pap test, Dr. Papanicolaou did a great job by creating the Pap test. However, that was a not fully accurate test. In fact, it had a false negative rate of up to 50%. And so for me, with the advance of my cancer, my oncologist said that I fell through the cracks at least 5 years. So 5 times to the doctor, they said, you're good to go, babe, you're good to go rock and roll. But actually, my cells were changing. And so it was the liquid Pap that ended up catching my cancer. And so I was like, well, wow, if that's a more accurate Pap, shouldn't everybody get the liquid? And my doctor was like, yeah, but it's a little more expensive. Not everybody's using it yet. And I'm like, well, that's ridiculous. Like, if there's a better tool, that's got to be out there. And I said, what about this HPV thing? I've never even heard about that. And this was 2002 at this point. And she said, well, actually, they just came out with an HPV DNA test that can be done with the Pap test for women 30 and up. And that is to test for the presence of the virus even before the cells start to change. And I thought that was wicked cool. I was like, oh, my gosh, that's a really great advancement. So I started talking to my friends, to my family, to people at the grocery store in aisle 6. I'd be like, hey, have you heard about HPV? Have you gone to your Pap lately? And I realized that there was such a lack of information out there that I felt obligated to do it on a larger level. And so I took my music and I got some bands together and I said, hey, let's have a concert and let's raise awareness so that women can know how important it is to go to their gynecologic exam and for them to be empowered and educated and able to say, hey, I'm 32 years old. I want an HPV test with my liquid Pap. Thank you very much. And so I called this first concert Pop Smear, because using pop music and Pap smears, and it really worked. And so I went on to do it on a much larger level with the Yellow Umbrella Tour, did 3 national tours in rock clubs across the country with all kinds of wonderful musicians to help me out, like Ben Folds, Sheryl Crow, The Fray, Duncan Sheik. And then in 2006, when the release of Gardasil came out, I was like, oh my gosh, that is amazing that there's a vaccine. Are you kidding? 3 shots at that time that could stop 70%. Now we've got the 9-valent one that could stop 90% of HPV cancers. It seems like a no-brainer, right? But so I went and with my music and the message into schools. And so now what I do is I go to universities and colleges and high schools and even middle schools, because nobody wants cancer. Nobody wants someone they love to get cancer. And so as I hear people, discuss more and more, and education has gotten out there, it's like I applaud you as healthcare providers and the opportunity that you have to make strong recommendations to parents that this is a vaccine that stops cancer, period. This is a beautiful thing, and I'm so proud to be a part of this movement, and I thank you for including the voice of the survivor as part of a motivating factor, because the reality is I did lose my fertility. We did try to do IVF, and it failed miserably, as did then my marriage. And I have side effects from my treatment, like radiation enteritis, that affect me today. I'm 16 years out, and they say, yeah, this is with you for life. And I'm always looking over my shoulder. Like, if I have a cough, if I have a bruise, if I have a hangnail, it's like, oh my God, it's a cancer. Because once you've been told that, you know what that's like. And for me, the reality is I did have 2 other potentially life-threatening things happen after cancer, the result of my compromised immune system. I contracted a tuberculosis-like infection in my lung, and they had to remove part of my right lobe. And then I got a spine-eating infection, Propionibacterium osteomyelitis, that ate an inch of my spine. And that's part of the reason is because I was nuked, because I was fried, because I was toxic. And so my system, is not quite the same as it was before. But nevertheless, I am one of the lucky ones. I am still here and telling my story and trying to make a difference in this world. So I thank you for asking me to be on this call. And I would like to say that there also is a wonderful documentary out right now that's called Someone You Love, the HPV Epidemic. And I'm honored to be one of the 5 women that are followed and highlighted in this film about how HPV and cervical cancer affected our lives. And it's a very educational as well as emotional documentary. And so I feel like that's another incredible resource that can be used not only in clinics but in schools and for families. So again, I thank you for having me.
Wow, Christine, that was a story I was not prepared to hear. I have heard survivor stories, but yours was incredible, and I want to make sure that everybody here in Alabama and Mississippi says, bless your heart. And we're very...
well, thank you so very much.
Your story is incredibly powerful, and I hope more people hear your story, because I think it would change a lot. It probably already has changed a lot of lives and a lot of opinions, and I'm hoping the providers who see this, which are from all 48 states, and I know there are 50, but we don't get Alaska and Hawaii, so there are providers across the United States that are watching this satellite broadcast, and hopefully they will take your story to heart and be able to share it with parents who are hesitant, and they themselves will have a stronger recommendation because they heard your story.
Well, thank you so much. I wish you all the best in your endeavors. Thank you very much.
You as well. Thank you, Christine.
You got it.
All righty. I guess we need to see about questions and answers, or our time is actually up, so I'm looking at someone in the control room to let me know if we need to go forward. Well, yes? Okay. We are taking questions both by phone and by email for at least 5 to 10 minutes, so if you have a call or question rather, please let us know and we'll try to get it in on this broadcast. You have anything, Miss Regina?
Yes. So I have a question. If someone misses a dose, can they restart it?
They don't have to, they don't quote-unquote restart it. They just pick up where they left off. So if they got the initial vaccine and then just kind of fell off as far as following up, they just pick back up where they left off. So it's not a restart. It's just picking back up and finishing it out.
I have another question. Is the vaccine still effective if you have had sexual intercourse?
Yes, the vaccine is effective and encouraged, whether you're sexually active or not sexually active.
Any questions on call-ins, Ryan? One is coming in, so we'll wait for the caller to come through.
While we're waiting, I have another question.
Yes, please.
Do women and men whose sexual orientation is same-sex need the HPV vaccination?
All need the HPV vaccination, all of them.
Okay, we do have a phone call from Springville. I am going to assume it's Mississippi or Alabama, but it could be any of the other states. But go ahead, caller. Something's going on. So you want to go with the next question? They're waiting for her to come, he or she to come.
Oh, I can hear you.
Oh, okay, there you
Okay.
are. Go ahead with your question, please.
Can you discuss something about cost, and will private insurance pay for the three vaccinations?
As far as private insurance is concerned, we recommend that you contact your insurance provider. The cost of the vaccine can be rather expensive, but as far as coverage goes, a lot of your private insurances are covering a lot more of these vaccinations. So we highly recommend that you contact your insurance carrier and ask them what is covered and what isn't covered. That's kind of the route of where we're going at this point. But again, the coverage is improving significantly than what it once was. So definitely don't let the fear of it not being covered deter you from checking into it or getting the vaccine.
I do want to also mention, after Natasha, about Medicaid. So we want to make sure that you know about the Vaccine for Children program. It's for children 0 to 18, and if they're Medicaid eligible, American Indian, or have no insurance at all, that providers across the nation, it's a federal entitlement program that you need to call a provider. And in your state, they can give you the list of VFC providers in the state, and then you can be provided the vaccine for free, and then there may be a nominal administration fee that they can charge you. I do know here in Alabama we really only have Blue Cross Blue Shield, and they are covering the vaccine. Once they were, the conversation occurred with them about how much they would save with giving the vaccine compared to any of these cancers. It was really a no-brainer for them. So that may be something, if you have to contact an insurance company, just ask them, how much do you pay for HPV cancer treatment?
Okay, thank you.
Thank you.
Thank you.
Any other calls? None at this time. You have another question,
One
Regina?
last question. If
Okay.
a provider does not offer the HPV vaccine, where can I get it?
Well, I think we're back to the Vaccine for Children. If they are eligible, depending on the state, here in Alabama we have county health departments, kind of the provider of last resort. Mississippi is Valerie on the line anymore? I don't know how Mississippi providers are. So I know the county health department situation is slowly fading away. So there are many states that don't have that option. So I would at least call your immunization division in your state and ask them specifically where they could go to get vaccinated.
There are also there are a lot of your pharmacies that are actually giving some of the vaccine as well. So your larger pharmacies, chains, Walmart, CVS, that sort of thing. There are some of your pharmacies that are now administering the vaccines as well for those who don't have it available in their clinics.
Right, and let me give a plug to the rural health centers and the FQHCs in all states. VFC vaccine is also available for those people who have insurance, but that does not cover HPV. So they would be able to get free vaccine through VFC and then pay the admin fee at each of those sites.
I didn't know that. That's good to know.
Yes.
Yay. Okay. Thank you.
We have a caller from Montgomery County. Go ahead, caller.
Yes, I would like to know if a young adult older than 26 can also...
It's not recommended at this time. The cutoff date is, or age is 26, so it is not recommended after age 26.
Right, for both male and female. Thank you. Anything else? All righty, checking one more time to see if there's any phone calls or emails coming through. There is not. I do want to thank Regina Knox, first and foremost. She is the Alabama AHEC coordinator, and she is the one who organized this and got Natasha and I and Christine Bays as well as Valerie Wood on the phone and brought all this together, and we really appreciate all your hard work and your coordination. I want to thank, of course, everybody here at Public Health that has put on this satellite broadcast, and I really want to thank each of you that is out there for your interest in wanting to know more and hopefully push the message and the vaccine forward.
Yes.
We really appreciate it. Have a great day.
Thank you.